Go for it, man. It's your show. You drive.
We're going to have a lot of fun. Well, everyone, welcome back to a very exciting episode of the Storybox podcast. Today, my friends, if you have ever struggled with SIBO, if you don't know what that actually is, or if you ever had any issues with the gut microbiome or don't know how that affects your overall health as a whole, then I'm delighted to welcome someone who is going to help us uncover all the mysteries surrounding that today. His name is Dr. Ali Rezaie. Now, for those of you that don't know who he is, he's the medical director of I practice this word, Dr. Ali, I promise you, and I still got it wrong. Gastrointestinal, there we go, GI, motility program at Cedars-Sinai, Los Angeles. He also serves as the director of bioengineering and Bioinformatics of the Medically Associated Science and Technology program, which is short for MAST. At Cedars-Sinai. Additionally, Dr. Rezaie is an associate professor at Cedars-Sinai and clinical associate professor at UCLA as well. So he gets around. He's a very busy man, as you can probably tell already. He graduated from the University of Calgary in Canada with a Master's of Science Epidemiology, believe it or not, and Big Data Analytics. He completed his residency and fellowship in internal medicine and gastroenterology. There we go again. It's a big word, people. At the University of Alberta and the University of Calgary as well. You have another book, which is an accompany to the Good Life Cookbook, which you were part of in terms of writing the foreword of the book, and I believe helping in some way, shape, or form. The Microbiome Connection, which is written by yourself and Dr. Mark Pimentel, if I'm saying that correctly, probably butchering, but anyway, which unpacks small intestinal bacterial overgrowth, which is known as SIBO, people. Not fun. I've had it and it sucks. It induces the low fermentation eating plan, but I could go on and on and on about your incredible achievements, Dr. Ali, but can I welcome you so much to the Storybox podcast today?
Thank you so much. Thanks for having me. Very excited to be here. And thanks for the kind introduction.
Well, hopefully I got all those words correct. There's a lot of big words. For those people that are listening to the audio, go and watch the YouTube video for the actual introduction that I just did. You can say, well done, Jay, for getting past all those words. But it just shows that you are very, very informative and talented in terms of all the incredible work that you are doing in the world. And you're in the scrubs today. For those people that can't see, he's still working and he's made the time to be here today, which I'm very grateful for. Dr. Ali, before we unbox more of your story and SIBO, gut microbiome, all that sort of stuff, the very first question that I have for you is a question I love asking all my guests at the very start, which is, what does success look like for you?
So that's a good question. I think success is when you set up realistic but yet achievable goals for you, and then you try your best to achieve those. And you may not potentially achieve those goals, but if you get to a point that you know that you have done your best to reach those goals, and that's success. And that's both on the professional side and also on the personal side, I have to say. Because, on professional side, for example, from the research standpoint, you set some achievable goals. You have some set points that, okay, I want to prove this concept. I want to do this test to help patients in terms of diagnosis and treatment. Well, sometimes it pans out, sometimes it doesn't. These are all theories and hypotheses that gets checked, but not achieving it is not real lack of success. You doing your best to get to those points, I think it's the success. That's I think that's the way to go, I would say.
I totally agree with you on that front. You got the personal version and you got the career version. I think people need to understand the differences between both of them and keeping them separate in some capacity. But when was the moment for you, Dr. Ali, that you realized that this was, in fact, these goals that you set for yourself was, in fact, the success for you? Has it been this sort of gradual thing over the course of your life where you've realized it at different moments? or is there more of a catalyst somewhere for you?
Well, in terms of you feeling that success in the field of medicine, I would say it's actually an easier field than other fields in the sense that your feedback comes from your patients. So when your patients come back to you and with the implementation of what you have done for them, and they feel relief and they're grateful to you, and that just has been the fruit of your research. I mean, that's success to me. That's say that, hey, I've helped someone. So when I get emails or even messages that say, hey, this treatment or this test that you helped develop and helped me immensely, helped me diagnose me and helped me understanding my disease and also help me treating it and get better. I mean, that's a sign of success to me. So I guess in medicine, we have it good because we have humans on the other side to give us feedback of how we're doing. So that's the gauge, I would say.
Why did you enter or decide to study in the field of medicine in the first place?
So I'm not going to give you the cliche of, I wanted to help like everybody that I see that starting at age 6. But no, when I was in high school, I really enjoyed biology. And not just human biology at any point of biology, and even zoology and botany. And because of that, I pursued medicine because I knew that is the most evidence-based part of biology. And I really like medicine. And as I was in med school, I was lucky to find a mentor that by chance, his field of research was mostly in drugs being developed in the field of gastroenterology, and the rest is history. So that's kind of how I got into it, a personal interest that I got into medicine, and then mentorship of a great mentor to begin with. Yeah.
What was it about gastroenterology that sort of fascinated you more than all the other areas of human health or the more biology of humans?
So, I mean, if you think about it, GI is quite a unique sort of set of organs put together. So we say it from gum to bum, essentially, all the organs, and each part does something different. And each part does have a role with its motility, the way it moves, the secretions of it, what it produces, and also the microbiome inside of it and how it digests the food, and also the immunology inside the GI tract. So it makes it a very fascinating part. In terms of gastroenterology itself, the science, it deals with the medical part of things. So you're dealing with diagnosis and treatment. And on top of it, you do a lot of interventions as well in terms of endoscopy, whether through the mouth or colonoscopy. So we do a lot of hands-on processes and interventions and procedures. So it's a very good amalgamation of medical knowledge plus interventions that we do to diagnose and also treat patients, which is rare in medicine. So many times you're on the surgical side that you're doing a lot of procedures, or you're on the side that you're doing a lot of medical parts without any procedures. So GI is kind of unique that we're kind of half surgeon, half medical doctors. So it's a good mix that keeps you going. And another field that I'm very interested in is device development. Because this is a device dependent specialty, so a lot of things are changing, a lot of innovations, and that is very exciting. And and this is the age of innovations and all new things that show up every day, and that's why this is a booming field, which I love to be.
I think it's a very interesting field because mainly I've had issues with my gut since, I guess, 2017, which entered me into hospital. So I had a massive bowel blockage, and it wasn't a fun time. Let's just say that. It's very gruesome. And I was under a gastro the second hospital trip. You heard me correctly. I was in hospital twice, a total of 9 days with this massive bowel blockage. So the last day of the last hospital trip, I was finally seen to by a gastro who helped me immensely get rid of the blockage. And we ended up doing a colonoscopy and an endoscope afterwards, which discovered that I had IBS and all that sort of stuff. All that to say, I'm curious so you probably look at a lot of different people, a lot of different illnesses that involve the gut, the microbiome, the gastro, the esophagus, all those things. What are some of the most common forms of illnesses that you end up treating on a day-to-day basis?
Sorry that you have gone through that, but one thing is that GI disorders are extremely common. But one thing that I'm going to tell you is that they're essentially, most of them are invisible illnesses. So from the outside, patients look really good, but they're suffering inside. And that's why for the longest time, a lot of GI disorders have been neglected. And that's a problem that's in our field that we have been trying really hard to overcome. So one of the diseases that are extremely common, and in fact, the most common disease is what you just said, irritable bowel syndrome or IBS, which I see a lot in my outpatient clinic. I would say 60 to 70% of the patients that I see in the clinic are IBS patients. Now, the irritable bowel syndrome is kind of an umbrella term in terms of what causes it. What it is essentially you have abdominal pain associated with change in bowel habits and stool consistency and stool frequency. So if you think about it, a lot of diseases that we can go through in detail if you want, that can cause those symptoms that you have to tease out. First diagnose, and then you try to figure out whether you can treat it or you need to modify the disease or you need some sort of maintenance therapy. So that's a very common disorder. Obviously, there are other common disorders, but by far, IBS is the most common luminal GI disorder that we have.
Why is it so common? And are there any sort of age ranges that it does affect the most? Or is it just particularly one set age group, like young people? Because I never had IBS before until 2017. So I think I was in my 20s. But before then, didn't have any issues. So is it just that it develops later on in life, or does kids still get it as well?
No, it can happen at any age, but the most common age of presentation is in your 20s and 30s and 40s. The why it's and the prevalence is increasing dramatically. So whether in the Western world or even in Asian countries, for example, Singapore has reported the prevalence of IBS increasing from 2% in 1990 to about 20% in 2020. So it's increasing dramatically. Now, why is it becoming more prevalent? One theory is that we're not having the same habits as we used to have 40 years ago, right? 40 years ago, the world was not a small village in terms of cultures and all that, right? So now these days, what do? We go out, we travel a lot. Well, not during COVID days, I guess, but we used to travel, and now we travel a lot as opposed to 4 decades ago. We we eat different ethnic food. We're exposed to different bugs and bacteria all over the world. Infectious gastroenteritis is becoming common. And every time you pick up infectious gastroenteritis or food poisoning, you have about 11% chance of developing post-infectious irritable bowel syndrome, which is becoming almost the most common single cause of irritable bowel syndrome, which is on the rise, and we see it in a lot of patients. For example, the classic story is that, hey, I traveled in North America, usually I traveled to Mexico, and there I picked up food poisoning. I had a little bit of diarrhea and then a little bit of a vomiting, but that subsided. But then after that, my bowels have never been the same. I have alternating bowel movements. Whenever I eat, I get bloated and distended. When I eat in the morning, I'm flat, but when I eat, my stomach gets more and more distended. By the evening, I feel like I'm 6 months pregnant. What's going on to me? And I didn't have any of these symptoms. So those are the usual scenario that I hear that patients recall. So many times, in fact, that episode of food poisoning could have been very mild. I went to Mexico and I don't remember if I got sick in that trip, but maybe I vomited a couple of times. I wasn't sure if it was food poisoning or it was the tequila. I don't know. But then now everything has changed. So even a mild food poisoning can cause trouble.
That's interesting because I didn't travel before. Yeah, I didn't go anywhere. Pretty much, I was stuck in Sydney, Australia. But what I did was I restricted the amount of foods that I did end up eating, which I think your gut needs a little bit more like food groups in it. And I only had like a select few, and I ate a 1 kilo bag of spinach pretty much every single day. So you can probably imagine that my gut wasn't happy at the result of me eating a ton of spinach plus mixed with cheese sauce, all these things. It was nuts, Dr. Ali. Crazy. And hopefully people can learn from my bad mistakes. But I'm curious about if someone does have IBS or they don't really know what to look out for. What are some of the main sort of symptoms? Because you did mention earlier that some illnesses with the gut, they can go undetected. So what should we look out for? Is IBS as well something that is undetectable for some people?
So essentially, the common symptoms that you will suffer is change in bowel habits. You used to have like 2 or 3 years ago, one bowel movement every day and well-formed. And now what you're experiencing is a change in bowel habits. Now it can be broken down into different categories. One category is IBS diarrhea, or diarrhea predominant irritable bowel syndrome. So patients with this subtype essentially present with more frequent bowel movements, and these frequent bowel movements are usually associated with urgency. Urgency meaning that, hey, when you have to go, you gotta go. And that's very not specific, but definitely present in patients with IBS. This is to a point that a lot of patients with IBS, for example, know all the bathrooms on the way to work. So they know, it's every 7-Eleven around the corner. Or every McDonald's, you know where to stop by, right? And then they have apps, for example, on their phone that tells them where is the closest bathroom, right? So, and if you look at these apps that tells you where the bathrooms are, they have been downloaded millions of times. That just shows you in silence how many people are suffering from GI disorders right there. Right. So that's urgency. So urgency is one problem that you will have. Another issue that is very common is what we call sensation of incomplete evacuation. That's a lot of word, but what it means is that after you have a bowel movement, that sensation of complete evacuation, that was like, oh yeah, I'm done. You don't get that. And that's one symptom that IBS patients have. The biggest problem that most patients have is bloating and abdominal distension. Just to differentiate bloating and distension is that bloating is that when you eat, you feel full, but you don't get visibly distended. Abdominal distension is that when you're like distended to a point that, okay, I have to switch to stretch pants or I have to go a couple of notches on my belt to feel comfortable. And that is also very common in patients with IBS. On top of that, patients experience early satiety. So you eat, and within 15 minutes to 1 hour after eating, you feel like, I just don't feel good. I feel gross, right? So you feel a sensation of indigestion. So that's one other symptom that is very common in IBS. And it also can have other symptoms as well, extra-intestinal manifestations of IBS, that goes beyond just the GI tract. For example, fatigue, very common in patients with IBS. Postprandial brain fog, meaning that after eating, you feel like, oh my God, why am I so sleepy? Why can't I not function? For example, I have a patient who works in a bank. And he says that, well, I was making mistakes after eating. So he's to a point that he doesn't eat while he's at work because he gets to that point of brain fog. So all those symptoms, they don't have to be all present in one patient. But if you have a few of them all together, that is possible that you're suffering from irritable bowel syndrome. And one of the main causes of irritable bowel syndrome that we'll get into in detail is SIBO that can cause all these problems.
So you can have IBS and SIBO at the same time, can't you?
Absolutely. So there is a big overlap between irritable bowel syndrome and SIBO. And this is kind of a concept that is coming about in recent years to a point that, let's step back a little bit. Remember, IBS and all these symptoms that I told you, if you go back to the literature 40, 50 years ago, even up to 30 years ago, or even if you ask a kind of like a old school doctor, they considered a psychosomatic disease. They would say that, well, oh no, this is a disease that it's just because of whatever stress or psychological stressor that you were under. Is just your brain is just telling you that you have these symptoms. There is nothing organically wrong. Yeah. Having said that, things changed in terms of pathophysiology and understanding of what's causing these symptoms. And one of those is the role of microbiome and also the small intestinal bacterial growth, or SIBO, in it. So a lot of IBS patients turned out to have SIBO. So treatment of SIBO will help with IBS patients. On the other side, there are some SIBO patients that they don't have IBS-like symptoms, so they present in different ways. So it's, if you think of a Venn diagram, there is not a perfect overlap. There is a separation, but there's a big overlap in between still.
Yeah, I ended up getting my SIBO after, I think it was a couple months later, but I want to go back a little bit and ask you regarding going to the toilet, like the more frequent change of bowel habits. Why is going more than once a day, why is that bad for our guts?
So it's not necessarily bad. So if you think about it, the normal range of bowel habits is actually one bowel movement every 3 days, all the way to 3 bowel movements a day. So it's a big range. It's the change. Every one of us is different, right? So for me, maybe it's normal to have like 2 bowel movements a day. 2 bowel movements a day for somebody else can be too much. So it's just that the way that the gut shapes itself and then gets affected by IBS, that you just have a change in bowel habits, and then that change obviously is not good for you, right? And that's makes a world of difference in terms of how it affects your microbiome and how it affects the function of your GI tract.
Yeah, right. Having IBS is not fun because I think it was very much like what you said. You kind of have this little bit of I wouldn't call it fear, but I think you don't want to eat because of the pain that you'll experience after eating. So you kind of hold off quite a bit. And I think you just restrict the eating window that you have, or I do at least, so that I don't feel bloated all the time. And because it always happens to me at nighttime. So in the morning, I'm fantastic. I am, love feeling empty. But then after I've eaten my first meal at lunchtime, and then moving into the afternoon, I get fatigued. I get sometimes the brain fog, the pain, and it's interesting because I've changed my diet so many times. The one diet that really helped me overcome SIBO and IBS I still follow it technically today, was Dr. Stephen Gundry's diet, the plant paradox diet. So cutting things out that really did affect my gut microbiome, testing things, you name it. But it was interesting because of what you said earlier about stress, like the old days, because my old gastro, he said that to me as well. He's like, you have a habit of being too stressed. And when you are stressed, it goes down to your gut. So just be careful of that. Watch out for it. And you can probably help out your IBS a lot more. Did I listen? Probably not. Probably should. But that's really my whole experience, or has been my whole experience with IBS.
Yeah. I mean, there are multiple points that we can open up on what you said. So one thing about the stress that you mentioned, the story is actually interesting, right? So in 50s and 60s and 70s, people would say that, oh yeah, all those Wall Street people who are getting stress ulcers and the bleeding and all. So it's because they have the most stressful job. I don't know, out of all jobs, I don't know why Wall Street is considered super stressful, but anyhow, came again, Barry Marshall from Australia, and figure out the H. pylori is causing the ulcers. And also on top of it, we know that smoking and drinking and eating fatty food is also bad as well. So on top of it, obviously, probably the worst lifestyle that people had was in Wall Street. So obviously they were the ones being affected the most. So it wasn't necessarily the stress. It was all those organic factors that we figured out. Now, a lot of patients come to me, and even myself, right? So during medical exams and all, I would always have changing bowel habits. So why is that? It's not specifically the stress itself, is the fact that how do we react to that stress? When we're stressed, well, we don't exercise, right? We start eating not the way we're supposed to, and we don't sleep well, and all those affect the GI tract, right? So when you're having an exam, obviously, instead of eating healthy, you're ordering pizza from God knows where, and then you're not sleeping, right? And then obviously you're not exercising either. So all of a sudden your lifestyle is changed and your gut reacts to it. But the thing is that reaction, the easiest explanation is that, oh yeah, I'm just stressed about the exam. But there are other factors that goes into how you react to that stressful scenario that affects your gut very organically. So that's very important. One thing that you said that was very fascinating, and I think we should open that up, is that you said in the morning you feel great, and as the day goes along, things get worse. One of the main reasons people thought IBS is psychosomatic 40 years ago is that, first of all, when you sleep, it doesn't wake you up. And also when you wake up in the morning, you feel great. So people will say, well, you see, I told you it's in your head, because when you sleep, it's all good. But now we understand why it's happening, and allow me to kind of maybe open this up in 2 or 3 minutes so we understand the pathophysiology. So in early 90s, we started to do something called antroduodenal manometry. It's a catheter that goes through the nose, goes into the esophagus, and then into the small bowel. So what it shows is the contraction of the bowel. Until then, we didn't know that the bowel actually functions in a very organized way. So when you eat, let's say that something heavy, including proteins and also a greasy food, it goes into your stomach. You go into something we call feeding phase. Now, in the feeding phase, food sits in the stomach, and stomach starts to grind and titrate the food and mix it with the acid and the enzymes. That combination of food with the acid is called chyme. So it needs to be broken down into 1 millimeter pieces until the sphincter between the stomach and the small bowel to allows it to go through. So when that chyme enters the small bowel, at that stage, you enter the fasting phase. And the fasting stage of this small bowel is clockwork. It has 3 phases. Number 1 is silence. So essentially it waits for the chyme to go into the small bowel. Remember, its stomach is acidic, right? So it has to go to the small bowel, and the bicarbonate from the pancreas comes in and mix up with it. So it has neutral pH right now. Waits for that to happen, and then it gets mixed up with the enzyme in the small bowel. Then phase 2 starts. Phase 2 is actually very neat as well. So it is non-propagating contractions of the small bowel that mixes the food, mixes with the enzymes, and also gets it closer to the lining of the bowel, which are these tiny villi are sitting, and the food gets absorbed by these tiny villi, and then goes and the nutrients go inside our body. So this happens so we can get nutrients from the food. And remember, the small bowel is not a small organ; it's 6 meters, and its surface area is as big as a tennis court. You know, just your eventful Melbourne Grand Slam was just happening. Anyway, so it's just so anyways, so that it's a big surface. But then after that, a magical wave that I call it, because I study it, I call it magical, but it's called housekeeper waves. Housekeeper waves happen every 90 to 120 minutes, start from the beginning of the small bowel, sweep through the small bowel, and dump everything, including residual food, residual enzymes, and also the bacteria that are in the colon come back to the small bowel, back to the colon, the large bowel. So that is integral for the health of the small bowel and also the gut. And those waves are affected in IBS patients. About 70% of IBS patients, those waves are infrequent, or weak, or they don't exist at all. So I said something about bacteria creeping back from the colon into the small bowel, which now we're getting into the microbiome and SIBO part of these things. So remember, our mouth is relatively dirty. It's about 1 billion bacteria sitting per ml in our mouth. We're just hanging out right now that I'm talking with you. Right. In the colon, it's even worse. It's 1 trillion bacteria per ml, per cc.
Even if you brush your teeth.
Oh, yeah. Even if you brush the teeth, man, they're still hanging out. Right.
Oh.
But in the small bowel, magically, it's less than 1,000. So in between literally these 2 dirty areas, small bowel is sitting there in a relatively sterile condition. So how does it do it? The most important thing is this housekeeper wave. It doesn't have antibiotic. These housekeeping wave, by massaging it, can keep kicking out the bacteria into the colon. Because the bacteria in the colon, there's so much bacteria in the colon. Because, remember, there are more bacteria in our colon that we have cells in our body, right? So we're literally more bacteria at the end of the day than humans. But these bacteria in the colon creep back up into the small bowel constantly. Why? Because these are not stupid. They're like, okay, why am I sitting in the colon literally eating crap while there's fresh food up there, right? Mm-hmm. So they creep back up into the small bowel. But the housekeeper waves say that, oh, no, not here. Go back where you are. Now, if these waves are affected, like a lot of IBS patients, the bacteria in the colon come to the small bowel, and now you have a lot of bacteria sitting in the small bowel, overpopulating because there's a lot of food there. And now when you eat, instead of you digesting it, the bacteria digest it. What do bacteria do when they digest? They ferment. They produce gas. They produce hydrogen sulfide, methane, carbon dioxide, right? And that makes the small bowel like a party balloon full of gas. You feel bloated and distended, and that gas can't move forward because small bowel is skilled to push food forward, not gas. Our colon is obviously skilled to push gas forward, but not small bowel. So it gets confused. That's why a lot of SIBO patients said, hey, my gas is trapped inside of me. I can't belch it out and I can't pass it as a flatulence. So I'm stuck. So what happens is that overnight, this gas dissipates into the bloodstream, some of it, and we breathe it out. And overnight, we don't eat. We're not feeding the bacteria, so there is no production of gas. Hence, in the morning, you wake up the best. As the day goes along, that food that you're eating, some of it gets fermented by the bacteria and they produce a lot of gas, and you get bloated and more distended. And that's how the system works. So it wasn't in people's head that they wake up with a flat abdomen and they are doing well when they're sleeping. They're doing well while sleeping because they're not eating. And you're not feeding the bacteria. And that was essentially the big change that happened in the world of IBS, to a point that a disease that was considered psychosomatic 40 years ago, all of a sudden there is an antibiotic approved by FDA for treatment of irritable bowel syndrome. So it's a complete shift of things that has happened in understanding of irritable bowel syndrome, with the help of microbiome. Sorry, that was a long explanation. I'm sorry.
No, I love it. I think this is all fascinating stuff because I am learning as I'm going along, even though I've looked at it so many different times and spoken to a number of gastros in the past. It's fascinating to see, like with my current symptoms, whether or not my SIBO has in fact come back. Because before, for me, I was actually burping quite a bit. I couldn't stop burping, and then farting quite a bit as well. So it was like, I think the SIBO, the gas wasn't remaining inside too much. It wanted to come out a lot. So I think that was a difference with me. And then when I went on the change of diet, that sort of shifted everything. So I wasn't burping as much and I wasn't farting as much. But the interesting thing is now, even though I'm not burping or farting much, I've got, I guess, that buildup. So I'm wondering if it's just staying there now. And yeah, it's an interesting thing, I think.
Yeah.
For me.
No, that's actually not uncommon either. Because remember, we can pass gas with the gas that is in the colon. We can burp with the gas that is in the stomach. So there's going to be gas in those areas. But with the small bowel, we can't do much, and that's where you feel the action right now. And then that is a very common complaint about that patients have. So you talked about the diet, and essentially why diet helps is that, so bacteria love to eat sugar. Bacteria love to eat carbohydrates, right? If you leave olive oil out there, it can sit there thousands of years. No bacteria is gonna eat that. But if you pour a little bit of sugar on top and mix it, and then 2 days later there's gonna be mold on it and whatever. So right. So they love sugar and they thrive on it. So The idea is to decrease the amount of carbohydrates in the diet and to move more towards digestible proteins and a moderate amount of fat, to have that type of diet to provide a less favorable environment for the bacteria to thrive on. And it's not going to kill them completely. It's not going to wipe them out, but it makes it harder for them to, multiply and having party in the small bowel, so then they do whatever they want to do, right? So that's the whole concept of diet, and that's why diets are so successful in controlling irritable bowel syndrome. Having said that, there are some diets that makes life even more miserable, that they're so restrictive. In Australia, for example, where you live, like the ingredients in the foods are quite immense, right? We're in California. There are like so many different ethnic foods and all that stuff. So you don't want to be going to that restaurant. You're that person that asks the server every single item that is in the food and all that, and there is nothing you can eat. Some of these diets are so restricted that you can't choose anything. So that was one of our goals with writing that cookbook, helping writing that cookbook, and also the other book, to help. Okay, these are the recipes that you can make to help you to have a normal social life, because at the end of the day, irritable bowel syndrome and SIBO, the good thing about it is that it doesn't become cancer. It doesn't ulcerate the bowel, but it affects the quality of life immensely. So it defeats the purpose if I give you a diet that I'm making your quality of life even worse by a super restrictive, like chicken and egg sort of diet. So that's what I was seeing that patients are suffering from. And this diet, over the years that we've developed over the last 15 years, has helped a lot of patients. We're like, okay, let's put it out there so a lot of patients can help. It can be helped.
Is one of the symptoms, this is just my mind spinning here a little bit, is one of the symptoms of SIBO and IBS, can it be night sweats?
So yes, it can. So it is, as I said, there is a set of, I didn't go into detail into it. We call it extraintestinal manifestations of SIBO. That can be brain fog, we mentioned it, the night sweats, the weight gain, and sometimes weight loss that can happen with patients. Insomnia is actually another a very common symptom that we see. Now, what causes it? We don't exactly know. That's actually one of the fields of research that we work on. What we think is that these bacteria, they're not just to produce gas. Remember, bacteria have been around. That's a living organism can produce. Anything that they produce, bacteria produces as well. So when they're exposed to it, they can produce different types of neurotransmitters. And these neurotransmitters can get into the blood, cause all sorts of symptoms. This can be histamine. Bacteria can produce histamine. They can produce serotonin. They can produce, interesting for you, that even like they produce sex hormones, whether male hormones or it can even produce female hormones. They can produce anything that you can think of. So depending on what type of bacteria has overgrown, they can produce side products that produces different side effects. So that's the science called metabolomics. That's what they produce and what molecules they can produce, and based on that we can figure out what causes the disease. So that's one of the fields that we work on. So yeah, definitely can cause night sweats.
This is why it's such a deadly disease. To be honest, like it affects so much of our body and our system. Like. Yeah, we need help to fix it. So what are some of the more common food groups or items besides sugar that do affect us eventually getting IBS and SIBO? Is it more wheat? those sorts of food groups?
Yeah. So there are multiple food groups that can sort of promote the growth of the bacteria. One group are the artificial sugars. These artificial sugars are sugar alcohols, the majority of them, except for example, aspartame, that is not a sugar alcohol. Sugar alcohols are made in a way that they are very sweet, but they don't get absorbed by us. But that is not true for the bacteria. Bacteria love sugar alcohol, so they can produce a lot of gas when they're exposed to it. So that's why a lot of people, when they take diet sodas, that they get bloated and they get abdominal distension. So that's one group that is affecting it. Interesting enough that you mentioned the wheat product and essentially gluten-containing food. Obviously, that's not a generalized rule, but there are patients with celiac disease that when they're exposed to gluten, then the small bowel becomes inflamed. When small bowel becomes inflamed, the motility gets affected, i.e. the housekeeper waves are not working. When housekeeper waves are not working, the bacteria overgrows. Now, you're not just gluten, anything else can cause trouble, right? So that's that. And also there are patients who are gluten sensitive, not all patients, but again, if you're gluten sensitive, then this whole process can repeat itself. Unfortunately, we are different in terms of our body composition, the genetic formation, and also the inherent normal microbiome that we have. So we don't react the same to the food that we eat. I mean, if you go out there, eat together, I mean, you will have different reactions to the same food. So there is no universal sort of like key that I can give you, say that, hey, don't eat these two things and you won't get IBS-like symptoms. That's not like that. It's a little bit of a try and error for a lot of patients to figure out, yeah, garlic definitely messes me up. Let's put that aside. But unlike a lot of people, lettuce, it's working fine with me, so I can take that. So a little bit of an experimentation needs to happen in each patient. And that's just the nature of how complex our bodies are. And you can't find a single diet that works. But the diet, for example, with low fermentation eating that we have is something that works in the majority of the patients, and it helps them significantly. Yeah.
I was looking through some of the recipes here, and leek shows up quite a bit. Leek seems to be like a superfood in a way. Eggs, that's all fine. Cabbage. So is kombucha okay as well?
Kombucha is, if you have filtered it, we generally okay it. But if it's like fresh kombucha with active fungi in it, I generally suggest not to take that, because that causes significant amount of bloating. I mean, there are a lot of food items that you can take without getting a lot of symptoms. For example, even from the green leaves that generally people say, oh, no, SIBO, do not take any vegetables. That's going to mess you up. That's not necessarily true. For example, spinach is okay. Arugula is okay. Leek is okay. Kale is okay. I know not many people are a fan of kale, but hey, kale is okay. Even bacteria don't like it. But those are all good. Berries are all good. Raspberries, blueberries, no problem. You can take those. And you said in terms of protein, chicken is okay, fish is okay, eggs are okay, pork is okay, and the oils are generally okay to make your food. A lot of spices are okay to be taken, and that's so that gives you a whole bunch of recipes. Another thing that actually causes trouble is not dairy itself, is the lactose in the dairy. Lactose is a disaccharide that is disaccharide means that the two single monosaccharide attached to each other. That is very fermentable and digestible for the bacteria. So a lot of people with lactose intolerance, in fact, have SIBO. It's just that when they drink milk, they get super sick. They think that they're lactose intolerant. So in my patients, I recommend that they go on lactose-free milk or try vegetable-based or a plant-based milks. For example, oat milk works really well with patients with SIBO. So those are the options that you have to get help with the diet.
Yeah. So how do we cure effectively? Can we cure IBS and can we cure SIBO as well? Is it mainly through diet or do we need help through medications?
And that's a great question. So I break it down into actually three pillars. The pillars are: one, are they modifiable underlying causes that you can get rid of, right? Number two, induction of remission, and three, maintenance of that remission. In terms of finding underlying modifiable causes, sometimes, for example, you have a mild brewing sort of small intestinal bacterial overgrowth that you treat it with a course of antibiotics, and then you go on a limited diet for a short period of time. You come out, you're good, you're done. So that's a mild disease that can be cured. It's actually in about 1/3 of the patients. Or if it's because you have some sort of small bowel pathology that is ongoing, that you find it. For example, if you have inflammation, is because of Crohn's disease, because of celiac disease, because of diseases that are affecting the small bowel, in a sense that it's causing tethering of the bowel, like adhesions that can be helped, and those can be fixed and your IBS goes away. For example, a lot of patients with narcotics have IBS-like symptoms. So obviously you have to work with the patient to get them off of narcotics, right? So those are modifiable causes that right now we can treat. Having said that, that is not the end. What we're researching on is the role of immunity, autoimmunity, and see if we can cure IBS in that regard as well. Mm-hmm. For example, I talked about food poisoning. I didn't go into detail why food poisoning causes IBS, and that's through autoimmunity. Autoimmunity means that your body, your immune system is attacking your system. So what happens is that when you get food poisoning, for example, with Campylobacter, what we discovered is that there is a protein inside of it. Name is not important, but the name is cytolethal dystenic toxin, or CDTB. So that protein goes inside your body, you produce antibodies against it. And those antibodies are similar to attack a similar protein in our body called vinculin. So there is molecular mimicry and attacks vinculin. Vinculin is in our body. The problem is that vinculin in our body is involved in the nerves of the gut talking with each other. So now you have antibodies against vinculin and the nerves can't talk. And the first thing that goes away when enteric nervous system is not working is those housekeeper waves go away. And those housekeeper go away, then SIBO comes, right? So essentially, if food poisoning leads to an immune reaction, that immune reaction leads to an autoimmunity. That autoimmunity damages the nerves of the gut. Damage of that nerves of the gut leads to effect on the motility of the gut, and that leads to change in microbiome. So essentially, this whole system, and that original bug that caused food poisoning is long gone. This is long side effects of this. So now you can imagine we're working on ways to get rid of this antibody via different modalities to help the gut now working better. So that would be a type of cure that is on the way. So there are a lot of drugs in the pipeline for patients that is coming. That is quite fascinating how it's working. The next step after, so sometimes you can't find that modifiable cause and say that, okay, now I have to treat the SIBO with antibiotics. And usually the antibiotics is the first route that we use, whether we use systemic antibiotics or preferably non-absorbable or poorly absorbable antibiotics. Poorly absorbable antibiotics are antibiotics that go through the gut. They don't get absorbed, so you don't get systemic side effects, but they prune the bacteria in the small bowel. So we treat the patients that way. And if it doesn't work, there you can use alternative antibiotics, or there is something called elemental diet that you can use to suppress the amount of bacteria. That's a whole sort of different sort of topic that we can talk about in detail if you want. So that's the induction of remission, meaning that you suppress the bacteria, and then next you go to maintenance of remission. How do I stop for the disease to come back? Well, number one is the diet. Try to put patients on a reasonable diet without restricting the patient too much. One important point that I need to mention is meal spacing. That's very important. What do I mean by meal spacing? Meaning that at least 8 hours of no eating overnight, and also 5 hours of not eating between meals. Why is it that important? Remember, the housekeeper waves only happen at the time of fasting. So they don't, when you eat, they don't happen. So if you continue to graze throughout the day, you'll get more and more bloated, no matter who you are, because the housekeeper waves are being suppressed. So that's another important thing. And the third thing that we use are medications that accentuate the housekeeper waves. So these medications help the housekeeper waves to get stronger and more frequent, right? And those are called pro-motility drugs. These are drugs that help the motility of the gut. Now, there are multiple one of them on the market, and you can try what works for each patient. So now the future of IBS in part is becoming how you modify the microbiome, whether through diet and elemental diet, and also how to repair the motility of the gut by giving medications that help the motility, or getting rid of the underlying modifiable cause to help with the motility of the gut. So that's where it's aiming at, which is quite a difference from 30, 40 years ago, that you would just show up at the office and we're like, okay, here's your antidepressant. Good luck. This will numb you and you won't, and this will help with your symptoms. Because, at the end of the day, there are a lot of diseases that you can just treat them with a Band-Aid and send the patient home. But getting to the root of it is what is satisfying both for doctors and also patients, and the fact that they will get a better care and to just move on. Yeah. Which
is why I like your approach to things. It's not just put a Band-Aid on it, move on. Let's get to the root cause of it. Yeah. And let's give people ways and strategies on how to heal, because that's part of health, right? It's part of, I guess, being a doctor and part of taking care of one's own self at the same time as too. So I've really enjoyed this conversation, Dr. Ali. You've answered so many questions and given me so much great advice. I mean, I could speak to you for hours about this stuff, believe you me. I mean, also last year, my audience is going to love this. Jay's got so many problems, or he's been through so much with his gut, poor guy. But they also discovered last year, just randomly, that I had esophageal esophagitis, or whatever it's called, in my esophagus.
It was eosinophilic esophagitis.
That's it. Yeah, I can never say it correctly, no matter how many times I practice. It's one of those things.
The easiest way is to just say EOE. That's it. It's good. People will know.
EOE. Yeah.
EOE.
That thing.
Yeah. All right.
That horrible thing.
Yeah.
But Yeah, that's pretty much they found it just on a whim. And they put me on medication for that. And I'm in sort of remission at the moment, but what that did was gave me nasty reflux. And I've got to watch reflux with my kidneys as well. It's like, right. It's a miracle I'm still living, Dr. Ali, by the sound of it.
But that's another common disease in young patients. But interesting enough, that also has a treatment, a proven evidence-based treatment via diet. So elemental diet that I mentioned, it's actually helped this disease as well. So just to break down what elemental diet means is that everything that we eat has essentially three components: carbohydrate, fat, and protein, right? Elemental diet is these components broken into their elemental pieces. So carbohydrates into mono and disaccharides, proteins into amino acids, and fat into fatty acids. So this food is the least allergenic food that you can take. Essentially, they come into essentially liquid form, and you take it and it gets absorbed within the first few feet of the small bowel. The advantage of that getting absorbed in the first few feet of the small bowel is that the rest of the bowel doesn't see food, so the bacteria and microbiome resets. So that suppresses small intestinal bacterial overgrowth. That has been shown to be even more effective than antibiotics in patients with SIBO. But interesting enough, it's also helpful in patients with EOE. Why? Because it's the least allergenic food that we have. In part, eosinophilic esophagitis is driven by allergies, and the main allergens that cause that are the food allergens. So you suppress that, this heals. So that's why probably you were mentioned that elemental diet to treat the disease, and also something called 6 food elimination diets to help with the eosinophilic esophagitis, which is it's interesting, this connection between the food and multiple GI disorders. And unfortunately, it's not uncommon to hear that patients with EOE have IBS as well and SIBO as well. So they go all hand in hand, because remember, eosinophilic esophagitis is infiltration of these eosinophils that are inflammatory cells. Whenever there is inflammation, the movement of that hollow organ becomes a little bit stiff.
Yeah.
Whenever there is abnormality of the movement, the bacteria inside changes, i.e. causes dysbiosis, i.e. causes SIBO, and that causes a problem. And a lot of this infiltration of eosinophils is not just limited to esophagus. Sometimes it goes all the way to stomach, small bowel, and all. And good data is coming out. Not just by our group, actually, Dr. Nick Talley in Australia is one of the pioneers in that field. It's close to you. It's actually he's in Newcastle, I think. Yeah, so great. It's very exciting times.
Go Australia.
You should talk with him too. Australia, yeah.
Well done.
Yeah.
I might need to go and see him as well, like, because I was told with my EOS that it could, if I don't treat it properly the right way, then it could develop into becoming throat cancer. Could be really, really bad depending on how many levels that I had. So yeah, I need to get a handle on that, I reckon. Yeah.
Yes. So it's you need to take control. But I mean, that's dealing with all these GI disorders. One thing is that don't lose hope. New things are coming. A lot of them can be helped with the diet and natural remedies, but there are a lot of effective medications as well for a lot of them. So you need to be informed and don't just brush it off. Some of these diseases can have complications, so you need to be on top of it. So you need to be a little bit disciplined.
Yeah, and be wise. Yeah, do that too. Listen to Dr. Ali. Don't listen to me. I'm just the one that's struggling through all these things and trying to figure out how to fix myself in the process, which is a lot of fun. Believe you me. But Dr. Ali, where do you want people to find you, connect with you, and learn more about your incredible work?
I'm on Twitter, so if they want to follow me, that's where we usually post our new research and what we are doing, and the books that we publish and the papers that we publish. That is usually like one every couple of weeks, a new paper comes out. And that's a good forum to get data out. So I would say that's a good sort of avenue to follow me. Yeah.
And you've also got the Microbiome Connection, which is a book people can go and get a copy of that. Is that correct?
That's correct. I mean, Dr. Pimentel and I so put together this book that essentially summarizes about 20 years of our works in one book in terms of the role of microbiome in GI health. And also role of microbiome and not just GI health, in health in general, that is coming out in April. So keep an eye on that.
Very exciting. And you're also part of the cookbook that I mentioned. He wrote the foreword with the other doctor, Dr. Pimentel, which you can go and get a copy of both of those books too, just to support Dr. Ali and the incredible work, and to say thank you so much for providing so much wisdom for everyone. Dr. Ali, my final question for you, this is my all-time favorite question. I ask everyone at the end of all my conversations. It's a hypothetical one, but I want you to imagine with me for a moment that you've been able to reach the age of 100. All your friends and your family have decided to put together a film for you of everything you've ever said and everything you've ever done. Don't ask me how in the world they got it all. We'll call it magic for the sake of argument. They've been able to get it and show it to you on your 100th birthday. What do you want that film to say and to show about your life?
Oh, I should have thought of this question before coming on the, but and then
on the spot, how do you feel?
On this podcast? But yeah, so again, kind of goes back to my definition of success, is that I set some goals for myself to achieve. I may not have achieved all of them, but I hope I have tried my best to get into those, because we work on multiple different things, and one of them obviously is the role of microbiome. We invented internal UV therapy to help patients as an alternative to antibiotics, and I'm pretty sure if I live to 100 years, so a lot of these have gone into multiple generations and innovations, and hopefully they are helping millions of patients at that time. And I think that is going to be the most fulfilling message if I make it to 100.
That's the crucial part, right? I've got to make it to 100 first.
Yeah. That would be a first in my family. But anyways.
You never know, man. You never know. You could be the first. How about that? That would be awesome. And you can look back at this podcast and say, hey, I said it here first.
I'm going to give you a call then.
Yeah. I don't know how old I'll be by that time. But anyway, Dr. Ali, thank you so much once again for your time with me today. Really did enjoy this conversation. But yeah, thank you so much for joining me on the Storybox podcast.
All right. Thank you so much for having me, Jay.